Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. This is actually a compilation of, I believe, 3 procedures that I had to resort to a St Bart's ear hook in order to remove the wax. So this is patient 1. Now, patient 1, the left ear, which is the ear that I took a recording of initially, was off the patient's left ear, and that was clear. There's no wax, no occlusion. And this is the patient's right ear, and you can see here there's some wax that's occluding the ear canal. And I started off with a standard Zollner suction probe in order to perform microsuction, and this wax is just past the first bend, so we're looking about between a half a centimetre and a centimetre into the ear canal. Almost immediately I kind of realised and noticed that I wasn't going to be able to remove this using the suction probe. So I went back in with the St Bart's ear hook. I embedded the tip of the hook into the core of the wax, which had a bit of keratin around the edge as well. And I then slowly extracted it. That's the patient's eardrum. So there was a bit of a thinning of the eardrum anteriorly to the right hand side. You'll see that in a moment when I take another examination of the patient's eardrum. So the blockage is gone, the occlusion's gone. We're just mopping up around the edge. Got quite a narrow ear canal there, quite a twisty one as well. And you can just see to the right hand side, the eardrum slightly thin, so it might have had a previous healed perforation. That's an image of the piece of wax embedded into the hook. Now this is patient 2. Now patient 2, this is the patient's left ear. Now this plug of wax isn't fully occluding, it's semi-occluding. I can visualise the eardrum in the distance. The eardrum to me looks retracted. It looks like it's sucked inwards, a bit like when you're on an aeroplane, and that's due to eustachian tube dysfunction. And there's a narrow tube behind the eardrum in the middle ear that connects to the back of the nose called the eustachian tube, and that's designed to equalise the air pressure. If that gets blocked at the back of the nose, there's no air behind the eardrum, so the eardrum gets sucked in like a vacuum, and it gives the eardrum the buckled appearance. So with this plug of wax, I've used both suction and a Jobson horn, but I've had to then again resort to an ear hook. I inserted the hook into the gap, and you can see this wax was really embedded against the base of the ear canal. It's really dry there, loads of skin adhesions. And I performed tympanometry, and we diagnosed the patient with eustachian tube dysfunction. So we recommended some nasal decongestant sprays, and hopefully that will clear. And this is patient 3. Now patient 3 again, this is the right ear. Started off with a Zollner suction probe again. Almost immediately I could tell that this wax is too hard. I'm not going to get a suction grip. Now this patient's also got otitis externa. They had embedded this wax. You can see at the bottom, that's where the cotton bud had been used to push the wax in. And you can see the imprint it's left behind. So I'm just gliding the hook superiorly to the roof of the wax plug, and then rotating it into the core, and I'm slowly coming away and out of the ear trying to extract this, but it's really lodged. I had to go back in a bit deeper this time. Now we're on the bony part of the ear canal here. We're going to be really gentle, and you can see this plug slowly moving forwards, and it's spinning like a ball. It's rotating as I'm bringing it out. So we're near the entrance now. We know that because it's all the cilia, all the hairs. Yes, so this patient's also got otitis externa, which is like an eczema psoriasis of the ear. And you'll see that once I've removed this plug, there's a lot of mushy, moist, dead skin. They've actually got water in the ear, which has got logged. So it's a waterlogged ear canal near the eardrum. It's all mushy, and I had to remove it off the eardrum. The eardrum's quite scarred, and you'll see that in a moment if you continue to watch. So just gone back into the hook, just trying to release this from the ear canal, and you can see the size of that plug, and you can see this keratin coating it. So we still can't visualise the eardrum. The eardrum is behind all this yellow mushy debris. So for this, we're going to have to go back to the Zollner suction probe and just lifting the debris off the eardrum at the base of the ear canal here. We're not trying to remove every little last speck here. The patient has already got some medications and antibiotic and steroid spray and acetic acid spray for this condition. But whilst they're here, I wanted to at least visualise the eardrum. You can see the back part of the eardrum there, so it's quite opaque, whereas the eardrum is typically translucent, so you can almost semi-see through the eardrum. this patient's got a really opaque eardrum, so it's really white in appearance. It's heavily scarred. They've got tympanosclerosis, which is scar tissue buildup, and that's due to chronic ear infections over the years. So we can see the full front part of the eardrum there and the bottom part of the eardrum. This is just the back now. The eardrum's fully visible now. So it's probably a bit more harder for you to recognise it because you don't get the normal landmarks as you normally would with a normal eardrum. The hammer bone, for one, that's the normal landmarks. It's the first bone in the middle ear which is attached to the eardrum. It's also known as a malleus. That typically runs vertically from 12 o'clock to the middle of the eardrum. And I can just see it there. There's a pink vertical line from 12 o'clock to the middle of the eardrum, and that's the patient's hammer bone. I'm just using a fine end suction probe here. We're directly on the eardrum, just trying to get some of this debris off the eardrum. So this is in the anterior recess. You can see this dead skin, and I've had to bend this fine end suction tip a bit just to get access. And we're going to be ever so gentle here because we don't want to make contact with the eardrum. We don't want to touch the bony part of the ear canal. So that'll be quite uncomfortable for the patient. So we just lifted that from the inferior recess. I'm quite happy with that. I think I'm just going to mop up a bit around the edge on the posterior canal wall and at the roof a bit more. But the patient can hear significantly better. So we're just on the posterior canal wall now. It's really mushy, this. It's quite a hard consistency to remove. With the combination of the spray and the natural migration of dead skin, now that I've cleaned the blockage, the patient should be okay. And I've obviously advised them to avoid water in the ear because water has contributed towards this mushy consistency of dead skin. So it's just a little bit left near the entrance. It's on the cartilaginous portion, so I can put a bit of pressure here. So I just want to remove this if I can. So just peeling that off the base of the ear canal. And in a moment, you'll see a still image of that plug. You can see all the keratin, all the white debris around the edge. I hope you enjoyed that compilation, guys, and you're all keeping well and safe, and you've had a great start to the new year. Take care. Bye.